Greetings, everyone. My name is Wayne Jennings, and I want to personally welcome you to our forum today. Our speaker will be discussing healthcare, a topic of critical importance to us right now, especially since Cuyahoga County ranks 75th out of Ohio's 88 counties in healthcare outcomes. Our Shaker Heights Unitarian congregation organizes forums on important topics as a congregational service to the community to support personal reflection, social action, and to encourage individual and collective growth for us all. We appreciate your participation. I'd now like to introduce the coordinator for today's forum, Dr. Jonathan Glauser, a physician at MetroHealth Medical System. He will introduce the topic and our speaker. Jonathan?
Thank you, Wayne. Greetings. As a member of the Unitarian Forum Committee, I am pleased to introduce our forum on healthcare this morning. Our discussion today will document the many ways in which MetroHealth is addressing the root causes of poor health, including the social and community determinants of health. MetroHealth's institution for H.O.P.E stands for Health, Opportunity, Partnership, and Empowerment. It's a strong, multifaceted program that engages many community partners and resources so more people and families in underserved neighborhoods can access what they need to grow, succeed, and be healthier. MetroHealth has an enormous investment in this program that is receiving national attention. Other imaginative endeavors started by MetroHealth have included projects to improve the economic prospects for its own neighborhood, to enhance resources for psychiatric patients, a problem across the country, and the establishment of ties within a Cleveland high school, completely unique in this country. It's likely it's the only high school within a hospital in the United States. I would like to introduce Dr. Akram Boutros, a physician. He is president and CEO of MetroHealth, a system which treats about 1.5 million patient visits per year with 600 doctors, 1,700 nurses, and 7,800 employees, of whom I am proud to count myself. Born in Egypt, Dr. Boutros moved to this country as a young adolescent. He has asked that I keep the introduction relatively brief. I shall mention that he has won dozens of awards for his community accomplishments and commitment. He serves on many boards. He has overseen an impressive expansion of health centers and hospitals during his tenure here. Metro has the oldest level 1 adult trauma and pediatric trauma center in the region. It is Ohio's only Ebola treatment center, the only regional burn center, and under his tenure, I can truthfully state that its mission has been exactly what a healthcare system should be. I count Dr. Boutros as a friend personally. I turn this over to Dr. Boutros. You should know that we'll open this discussion for Q&A at 10 o'clock. As you listen to Dr. Boutros, please check on the Q&A button with your questions. Dr. Boutros, it's all yours.
Thank you, Dr. Glauser. I really appreciate this opportunity to speak to the Unitarian community, and I'm delighted to be here. I'm going to talk to you a little bit less about what MetroHealth is doing, but much more about what's the future of healthcare, and I'll weave in what we are doing at MetroHealth to prepare for that. Let me just say that in the 9 years I have been in Cleveland, it has been a tremendous honor to lead the MetroHealth system and to become a member of this community. The past 2 years have been challenging in many ways, but I will also say to you, they have been the most invigorating in my career. The pandemic has taken us all by surprise and has really highlighted some significant things that we as a country and healthcare as an industry need to do significantly differently. As a result of this, I think there's going to be 5 fundamental changes in how this country approaches healthcare. So the first is the focus on more social determinants of health and equity. So what do I mean by that? Well, it is clear this pandemic has made bare that people of different races, ethnicities, socioeconomic status, language, all the variations of diversity are not receiving or have access or have the same outcomes of care. So that's been laid bare. It's been highlighted through this pandemic, and there's significant need to focus on that equity. And all the hospital systems, public health, and governmental agencies that I know and work with are now focusing on that. We also have understood, finally, I think, in the health system, that the care that you receive, the medical care that you receive, only accounts for 20% of the outcome. You've heard Mr. Jennings talk about how Cuyahoga County health outcomes are so poor. And they're not poor because you don't have access to good health care in Cuyahoga County. You actually may have it was ranked as the second most accessible healthcare city in the country. You have extraordinary access to healthcare. Everyone does. It is specifically because of the barriers to that care and the other things that happen in the community around it. So social determinants of health means things like transportation, education, economic opportunities, safe housing, stress, lots of other food insecurity. All of these things have a significant impact, and 80% of the outcome, 80% of your health outcome depends on that, and your behaviors and the result of these social determinants of health. Genetics and the care that you receive only accounts for 20% of your outcomes. For example, chronic stress in adults and children causes significant changes in children to their brain development, so that they can't make good decisions. If the constant barrage of epinephrine, the stress hormone, makes children as they're growing up be more reckless and unable to discern how to solve a problem. So their problem-solving skills becomes significantly impaired. And the delayed gratification, which most of us learn as children, that if you wait for something, it may be better than receiving it right away, that is also impaired. For adults, it causes more cancer, more heart disease, more diabetes. I can go on and on. So at MetroHealth, 4 years ago, we started the Institute for Hope. And it became the first institute in the country that doesn't deal with just one aspect of the social determinants of health. It deals with all aspects of the social determinants of health. So everything from education to workforce training to housing, all of those different things. So we're about to open up a 72 apartment low-income housing on our campus, and that apartment building called Via Sana has a significant reduction in cost. A studio apartment, if you are in the lower socioeconomic status of the different rings, will cost only $300 a month. That is a brand new apartment with all the amenities that you would hope for. So we are now also focusing on the next group of individuals who we think need significant access to well-maintained apartments, and those are our 65 and years and older friends who are living on a budget. And so MetroHealth is now put an RFP out through our CCH corporation, which is our own development corporation, to build somewhere around 300 to 400 apartments that are significantly rent adjusted, so that if two people live on Social Security alone, they will be able to afford those excellent amenities apartments that are safe. So you'll see more and more hospitals and health systems and governments focus on the social determinants of health and equity as an underlying principle. So the second thing that the pandemic has illustrated that we need to do more is more collaboration. That is more collaboration between health institutions, public health, the government, IT companies, education. When we were able to do that in the pandemic and do it well, the community did better, or each organization did better. So this collaboration, which really hasn't existed in my 30 years of leadership in healthcare institution, is going to continue. We are the Cleveland Clinic, University Hospitals, MetroHealth leadership, and Case Western, and the county executive, and now our new mayor. We're constantly in communication now. That never used to happen. It used to be that we wait till there's an event or a problem or something else that someone needs to address, and it would be very short-lived. Now we're working on a multitude of things to deal with just the overall enormous need for healthcare in our community. We have IT companies who are committing significant resources, and they're saying, we don't have to be paid for this. We want to support you to do that. One of those collaborations that we have that MetroHealth began a couple of years ago is called Unite Ohio. So we were the first organization to put dollars into this, and it provided free access for the social services agencies to be able to access patients who actually need, our patients who need certain services. So all these social services agencies were able to use, we paid for the installation of this software, and they're able to see that this patient is looking for, has food insecurity and needs some support. Cleveland Clinic joined us about 6 or 8 months ago, and University Hospitals is joining us now. And St. Vincent's also is on the Unite Ohio platform. So that collaboration using technology to be able to manage a patient's needs holistically, or a neighbor holistically, is going to be critically important. The third thing is that we've learned that the focus on the individual alone doesn't make change. So what do I mean by that? We need to be able to have more data than just the data that's available on individuals. We need to be able to look at large amounts of data across the country, so we're able to learn very, very quickly. And so that big data analytics and artificial intelligence are going to play a major role. I'll give you an example. There's a Case Western researcher who deals in data analytics. Today, when a male patient has an elevated prostate-specific antigen, we tend to do a sonogram or an MRI to look for a nodule, to look for something that can be biopsied. And if we can't find it, we do what are called random blind biopsies, right? So we are doing 20, 30 biopsies of a prostate to see in the hopes that we can get a sample that will show that it's positive for cancer or not. Through the big data analytics and looking at different signals, this researcher can pinpoint to an exact location that and the surgeon would have, the urologist would biopsy in the prostate, and it has almost 100% accuracy. So all of this data, all this analytics, all the phone calls that you have to do to the business centers and all of those things need to get significantly streamlined, and power of large computing and big data and analytics is going to play a very big role in this area. And I'll give you another clinical example. As you think, I think most of you know that there are innumerable number of antibiotics that can be used to treat patients with bronchitis or pneumonia and other things. Well, every physician has their own particular experience with those antibiotics. Because there's such a large variety of antibiotics, no physician really is the authority on what are the patient characteristics that this or even the infection characteristic that can be best treated with which antibiotics. Using large data, that becomes accessible to providers very easily, and we can have people get faster, quicker, without the need for hospitalization, who can go back to work quicker, who can be with their family quicker, who have a significant less morbidity. So this large data and analytics and artificial intelligence is really going to be the new wave of this. You may have heard the Cleveland Clinic and some other hospitals, health systems, and Microsoft have created a consortium that is looking to propagate the use of artificial intelligence and automation in the healthcare industry. So they just announced that, I think, last week. At MetroHealth, we've been participating with an organization called H.O.P.E. H.O.P.E is the electronic medical record of choice in America. It is has the largest number of patients on it, and one of our physicians leads the Cosmos project. The Cosmos project has all the data de-identified from all the health systems that use electronic medical records, and utility is for research so that we can figure out how to take care of patients. One of the first projects that was done utilizing Cosmos was to figure out what's happened during the early pandemic for children's vaccinations, and what's happened to preventive testing, colonoscopies, mammograms, and the like. So MetroHealth is very much involved in that, and we will continue to propagate this with our partners. Next one is the fourth thing that is going to really impact healthcare and has been significantly, I would say, had a 10-year acceleration, is the use of virtual care. Today, most people see telemedicine or virtual care as an adjunct to traditional care models. Traditional care models are, even though they purport to be patient-centric, they're really not. They're provider-centric. And the reason they're provider-centric is that you have to go to the provider, whether it's to see the doctor in the office, to have an ambulatory surgery procedure, to go to the emergency room, to have a hospital admission, to anything that you need it's your, to have a blood test, to get your x-rays done, anything you need, you have to come to us. That's very much like banking 20 years ago. You had to go to the bank to have any kind of interaction. So right now, that's traditional care, where literally 90%, 95% of the care that you receive has to be done in our sites, not where you live, not where you work, not places that you want to be in. So that's traditional care models. And during the pandemic early on, we began using telemedicine to augment that. So at MetroHealth, we very quickly, we used to do less than 1% of our outpatient visits as telemedicine before the pandemic. In April of last year, we went up to 85% of the care was being provided that way. Now we're about 25%. As I said, most of that is just an additive to traditional care. What I'm talking about, a virtual care transformation, is that it gets the primary interaction happens at the patient's sites where the patient wants to be, happen in their home, and all of them are either virtual or at site care. So what do I mean by that? Instead of 95% of the care happening on our sites, it would end up that about 40% of the care happens on our sites. So we have developed a company called Ovation, the MetroHealth system has, and we are partnering with other healthcare systems throughout the country and IT solutions companies. 2 weeks ago, we put a request out for folks to help us build this new platform, and Amazon, Google, Microsoft all responded and want to invest in this program. But imagine that most of your doctor's visits are happening while you are sitting at home. Your blood pressure is being taken while you're sitting at home, your temperature, your weight, everything else. The doctor can listen to your lungs, can do an EKG on you, and do everything that you need in the comfort of your own home. You can have access to that physician or the provider 24 hours a day, 7 days a week, and you will be able to have them give you advice and also check on you for what we call self-management or guided management of healthcare. If a patient has an issue and may think that they need to go to the emergency department, the virtual care model would deploy an EMT to the person's home, evaluate them, be able to provide care there in order to avoid emergency room visit. And if they need to be admitted, they can be admitted to the patient's home as an inpatient, as a hospital patient. They can be in the home. So we bring all the equipment and everything else to the patient's home. MetroHealth already does that. We have a program called Hospital in the Home, in which we provide these services to patients. We bring in all the equipment, set it up, and we can take care of patients in the home. And we will send a nurse practitioner or a physician's assistant or a physician to be there with the patient early on and make sure they get through the acute part of the episode. The patient can get IV medication, can get all the different things. And this is wonderful for a couple of reasons. One, it reduces the risk of injury because it's your home, you understand where everything else. It reduces the risk of confusion, the risk of infection. People get better a lot quicker. About 30% of the medical admissions that happen to a hospital can be cared for in this manner. And this is such an important part that Medicare has awarded MetroHealth a contract that says you will get, MetroHealth will be paid exact same thing if they take care of the exact same amount of money, whether they take care of a Medicare patient in the home or in the hospital, as long as they're delivering the same exact care. So we are doing that today, and it's going really well. We're learning a great deal. Our aim is within 5 years that we will be able to deliver some of the same ICU care, the care that you get in an ICU at a health system, that you will be able to deliver it at home. So for example, if somebody's in the ICU for 8 days, maybe the first 4 days will be in an in-hospital ICU bed, and the next 4 days of convalescence will be in a home ICU bed. Hospice care can be also provided this care, and we can bring to patients mobile CAT scanners, blood drawing, dialysis, all the different things that can be provided are typically associated with the patient coming to a facility. So this virtual care platform is absolutely the future. It's been accelerated, as I said, within, because of the pandemic, we had 10-year acceleration of this adoption. And you will see this coming up and being utilized across the nation, I think, in the next couple of years. You also need to understand this is the Great Equalizer. It will be available whether to patients who are uninsured, who have significant amount of disposable income, who are in Medicare, who are in Medicaid. It creates a model that is affordable for everybody. The government will pay for it, and it will be able to provide the services. And people don't have to uproot their lives, or do not have to have time that they can leave their job to do this. Some of the barriers are folks who are in entry-level jobs don't have the time or the permission to go get their preventive care. The last thing is this personalized medicine. And personalized medicine, I started with kind of population and social determinants of health, which is very population-based. And I'm going to end with personalized medicine. Personalized medicine is, today, we say this medication is best for this type of cancer or this type of hypertension in this individual with these demographics. But as we've seen with, for example, with COVID, people's reaction to COVID varies tremendously. There are some risks that we have not figured out yet. And what we're figuring out is that human beings are infinitely different biologically, and they respond very differently. So I'll give you an example that you may be of interest to you. So there are some cancers that have been, and especially types of leukemias and lymphomas, which are blood cancers, which have been determined to be incurable, that they typically kill patients. One of our scientists, Dr. William C. at the MetroHealth system, has developed, and we're in his lab here, and we're developing in 3 more labs, is able to take cancer cells from a patient and then find specifically what makes them, what is the protein sequence that makes those cancer cells cancerous or different? How does it become different from a regular cell? He takes that portion, isolates the DNA, takes that DNA, injects it into a virus, and makes a virus that looks as if it's a cancer cell. Takes the patient's own white blood cells and exposes them to this virus. So there's a white blood cell called the CAR T cell, and that CAR T cell learns that this cell is a because of the virus learns that it is a foreign cell that needs to be killed. The reason cancer cells survive is because our own immune system doesn't recognize it as a bad thing. It lets it grow. If it recognized it as a bad thing, if it recognized it as a foreign matter, it would go and kill it and get rid of it. He trains people's own CAR T cells to recognize that cancer as that. So he's done that already. He is expanding its use across different areas, and that is highly personalized. So my CAR T cells would be trained to kill whatever cancer I have. That is only works for Akron Boutros. It doesn't work for anyone else. And so this personalized care that we are developing is critically important to be able to take care of patients that way. That's going to create significant longevity of individuals. And you look at that and then you say, well, if we're going to have a lot more people live a lot longer, we need more care providers. Well, the virtual care enterprise that I mentioned is how we're going to support the increase in population and longevity, because one provider is going to be able to take care of a lot more patients. And we're going to be able to do a lot of prevention and a lot of focus on how to prevent people from needing hospitalization or surgery or getting sick because of the big data. And we will also be able to support that with not just health systems, but other agencies. And that will come from the collaboration. And finally, that will give us enough time and focus to be able to take care of the social determinants of health. So just to wrap up, I mentioned all of them, but here's what the pandemic has done, and here's what MetroHealth is focused. We are more focused on equity and social determinants of health than just medical care. More collaborations between the various agencies and health systems and IT companies and governmental agencies and educational systems. Big data analytics and artificial intelligence are very important. The virtual care enterprise will become the a significant portion of the healthcare system, and then personalized medicine is going to pinpoint and take care of people in a way that we've never done before. So I'm going to stop here, and I think thank you for giving me your time and attention, and we'll be able to take some questions and answers. Take some questions. So I'll just stop here.
Thank you, Dr. Boutros, for an excellent presentation. I know I speak for the audience when I say we all learned valuable information about healthcare, Metro's programs, and its impact on our community. It's now time for questions and answers. Please look for the Q&A button on your screen and type in your questions. I will now turn this over to Debbie Wright and Laura Imbornoni, members of our forum committee and co-chairs of our Q&A session. They will choose the questions or comments you've typed in via the Q&A button. I see a lot of questions already. And if your question is chosen, they will recognize you by your first name unless you hit the anonymous button. Debbie and Laura, this is on you.
I really have one I'd like to start with. I appreciate your talk. It's really interesting. I love all these new ways that healthcare can be provided. My question is how patients access the system. How do you know which doctor or provider or clinician you want to see? And will give you an example. I was looking at MetroHealth's website, and I thought, well, how do I find contraception or birth control? And in your website, there is nothing that gives me providers. It sends me to the OBGYN department. The OBGYN department only talks about prenatal care, and the care of pregnant women talks nothing about contraceptive care. So if I want to find a clinician who has something I'm interested or need, how do I do that? There's no screening mechanisms. I mean, your clinic at least talks about providers beyond physicians, but say Cleveland Clinic only talks about physicians in their list. So how do patients find the right clinician that is good at what they need done?
So Debbie, access is navigating the system. I'll just put it this way.
Right,
Navigating the system is one of the largest obstacles there is. You often, I'll get calls because of a family or a friend or a patient who says, I can't do this anymore. I'm getting nowhere. So you're talking about just even in the beginning of the process, how do we do that? And this is where technology is going to be really important, this artificial intelligence and the like. We are building something called the chatbot that will actually, you will be able to say exactly what you try to do here. You will have a chatbot come up and you say, I am looking for contraception. The chatbot through its intelligence system will be able to say, ask you questions and say, so Debbie, are you having any of these issues? Because if you're having certain medical issues, you would have to go to a specialist, and we'll ask you all of those things. And then it will say to you, ask you where you live, ask you the availability, and then we'll be able to say to you, here are 3 people that you can see. Here's a nurse practitioner, here's a family doctor, and here's an OBGYN. And these people have availability when you want them to have availability.
So are you working on this system? I mean,
we are building the chatbots right now.
Okay, because that to me is the biggest thing. There's so many options. There's almost too many options in this area for healthcare. You know who to go to.
But Debbie, that's the start, right?
Mm-hmm.
The real problems actually happen after you access the healthcare system. And you need to go from one provider to another, or there's a medical issue that seems to be not addressed by one provider or one specialist or another. Mm-hmm. That actually becomes even a larger problem. And we're looking through how do we manage that. Today, we have humans who help you do this, who are called care navigators.
Well, it's hard to actually find those healthcare navigators. I've personally never seen them. You know, you can end up seeing a doctor who doesn't even address the problem you have. But yeah, anyway, I'm glad you're working on that. That seems like an important aspect. How about electronic medical systems talking to each other across the systems?
The government has required that they all speak to each other, and that's happening. And also, this is not a lot of healthcare systems that want to tell you this, but it used to be viewed as your medical information sits on our platforms, mm-hmm. Therefore we own it.
Right.
You don't. You can have access to it, but you don't actually own the medical information. The government has changed things around and has said that you must have access to it within 2 days in the format that's exportable, or this is your insurance company, this is your social services agency, this is your healthcare, or we pay fines.
Whoa. So what happens? Oh my goodness, your clinicians must be paying a lot of money.
Yeah, so we have adopted this, and anybody who's asked us for it, we've been in the past 6 months have been able to export their data in a format that can be utilized.
That's a huge change. Hey, Laura, you probably have a question.
You know, I do, Debbie, and I have to say that the question you asked initially about access to doctors at MetroHealth, I can see why someone would ask that, because I think, Dr. Boutros, after listening to you speak, a lot of us would like for a doctor from MetroHealth to take care of us. Maybe you even to take care of us with the
Laura, the reason you don't want me is I haven't practiced medicine for 17 years, so I'm just the wrong guy.
Yeah, but you're so involved in making it all happen with the emphasis on the whole person and personalized care. And we do have some great questions. I'll say we have a bountiful number of attendees listening here with us today for this first forum. So the first question I'd like to bring you is one from Ken. He says, at the H.O.P.E Cuyahoga County website, the worst health outcomes were identified as being in the urban core. And he's talking about the Cleveland area and the inner ring. He says 1 in 4 people in Cuyahoga County and 1 in 2 people in the city of Cleveland are living in areas that lack access to healthy food options, referred to as food deserts. Can you comment on access to quality food and health outcomes?
Yeah, so I will tell you is that we started looking at this about 5 years ago, and we began with a food pharmacy at the MetroHealth system. So for specific diseases, diabetes, hypertension, heart failure, and others, a doctor will actually write you a prescription for healthy food. You will go down to our food pantry. You will have a nutritionist go down there and give you free food. And we actually have access to recipes that will keep your blood pressure under control, your diabetes in control, or your heart failure in check. We also partner with the Greater Cleveland Food Bank, and as a result, we give away. I think last year we gave away 3 tons of produce to the community in these food deserts. We have them in the Buckeye neighborhood. We have them on the main campus. So this relationship with other organizations is critically important. I think you saw that on the UH campus now, the Women's and Children's campus on 55th and not sure if it's Euclid or something around Euclid. There's a Dave's that was opened in that area because of a food desert. The Cleveland Clinic is putting also Myers on their campus. MetroHealth is working with local providers to also do the same thing in one of the buildings that will house the senior care apartments. So we're all working through this process, and I think more health systems and more agencies need to collaborate to be able to do that. If you don't have transportation and you have limited income, or you are in a SNAP program and you depended on walking, you end up going to convenience stores or gas stations to get your food. And you have to see what's in there. It's completely unhealthy. Everything that's there is full of sugar, full of saturated fats, and processed. So we need to be able to make it much more accessible for people to have healthy food.
Well, my question is like, okay, you have these systems to access these other services, but who's doing that? Sort of Beth sort of asked, you've got all these need for this computer time, but yet, you went into medicine because you're interested in talking and interacting with people, but now you're interacting with a machine, and then you have to type up everything you've just done. And what kind of clinician buy-in do you have? Is it the clinician who sees the patient is doing this, or is the nursing staff who's rooming it? And how do you train the people to use this system? Because it is I see people struggling with Epic already, and this is on top of the Epic that they're already working with.
Yeah, so this is really important. So we need to have people do what they do best. So Dr. Glauser's, for example, is an excellent emergency room physician. That means examining the patient, getting the data, making diagnosis, looking at beginning a treatment plan that will keep them safe. I want him to continue doing that. So for example, when he's in the emergency room, he doesn't usually write his notes in Epic. He has a scribe that is listening to everything he's doing and is putting that in. There is now a program that we're looking at that as long as he talks, it takes all his words and enters them into the Epic system without him having to type them in. There are support staff. So I will give you an example. Doctors are really important and they do a great job. We found out at MetroHealth is that we had, if you came in with sepsis, we had a mortality rate and a morbidity rate. So you either died or became sick at an unacceptable level to MetroHealth. We spoke to the doctors about it. We spoke to the nurses. It got a little better. We then put a PhD pharmacist, a PharmD, in the emergency room and empowered them with data that would say, this patient must get their antibiotic quickly or they're going to have issues. That PharmD, working with the physician, reduced the amount of time by 60% of when the patient gets the medication. And that resulted in a 70% reduction of morbidity and mortality. So the doctor had very little to do with it. We provided an expert in this area, and they are now working in conjunction with the physician to provide better services.
Back to access to healthcare, and this is all about digitality and that first phone call where it says click 1 if you want this, click 2 if you click that, click 3 if you want that, and here's someone, let's say 85, trying to navigate. One of our attendees says access via technology is a generational thing. It's much harder to do if you are older. Another of our attendees, Gail, says, Dr. Boutros, how can you help guide people like myself who are older and not computer literate?
And adding on to that, one anonymous who's a physician says, I know plenty of people who cannot describe their problems well. My experience in commercial spaces with chatbots is they often can't figure out what I need, or they give me answers that don't solve my problem. And if you're not computers to begin with, all this becomes even worse. So it's
and then one more thing. Amy talks about the digital divide and the fact that there are people in the inner city who don't even have access to the internet. And how do you manage all that?
So at MetroHealth, we've trained over 565 plus older individuals to learn how to utilize the technology. And working with other folks, we gave them a laptop for free. We trained them. They passed the training program, so they now know how to use it.
Wow.
And we also have given them through our relationship with Dollar Bank, internet access that is cost $20 a month. Dollar Bank gives them a $10 voucher per month. So it costs only $10 a month to have high-speed internet access and training and also a computer. So we've done that already in multiple locations around the MetroHealth system. Now, I will tell you is that the state of Ohio and Cuyahoga County and the city of Cleveland are working together to make that, and some of the foundations, to make that accessible to everybody. So that's how we're doing it. And we're working with a Digital C to train folks and to give access that is significantly reduced in cost. Regarding chatbots and all of those things, I'm not telling you that today they work. I'm not saying to you that they're a panacea here. I'm telling you is that they're a start and they're going to get better. Google search engines 15 years ago were terrible. Today, before you finish typing in your question, it already has figured it out. So we just keep getting better and better at these things. And then finally, I would just say this to you. Remember, I said this is going to be personalized care. The minute a chatbot isn't helping you or anything else, all you have to do is press the button and you will get a human being who's able to speak to you about it, right? So we do not have enough providers who are going to be able to do this for every person. So we're going to have to use technology to extend the provider reach. I'll give you an example that I was involved in 20 years ago. I had just graduated from Harvard Business School, and a colleague in that school said, "Will you help me think through a problem?" I said, "Well, that seems to be the problem." He said, "We have in West Africa, about 80 or 90% of the nurses and doctors that graduate each year from one of the medical schools or the nursing schools in West Africa leave West Africa, and go to Australia, Germany, Europe, because they can make 10 times, sometimes 30 times the amount of money." So we're educating all those folks, and then we don't have any healthcare providers. So he developed a system, and I assisted him doing that, in which we took high school students and we trained them for 6 months how to do blood pressures, how to do different rudimentary exams, weights, look in people's eyes, all of those different things. Each one of these students was then healthcare workers, was assigned to a village, and they would see go to 10 locations, either 10 families or 10 people a day. They had cell phones. You may not have had running water in that village, but you had cell towers. So they had cell phones, and healthcare workers, so 10 patients, each 10 healthcare workers were attached to a nurse who had a car and who had lots of stuff in the car. They had IVs, they had medications, they had everything else. So for those patients out of the 100 that were seen every day who needed a nursing intervention, they actually went there and intervened so that the patient didn't have to come to go see a doctor. And every 10 nurses were attached to one provider. And these nurses now had a lot more equipment to be able to do that. So one provider was able to manage 1,000 visits a day. Okay, that's in Ghana. One provider managing 1,000 visits a day. That is how you extend the care across the enterprise. And what we found out, which was really unusual, is that if you are a villager, you didn't trust the doctors. You didn't know who they were. You've never seen a doctor. You didn't do that. After a while, because you had somebody come to take care of you, and you got used to the healthcare worker, and you got used to the nurse coming to see you, when they said that you needed to come and go to the doctor for the big city, they did it. And they said is that basically you invested in me, and I now trust you. So we're going to have to do the same thing, because there are people who don't want to see physicians and don't want to go to the emergency room and don't want to access the healthcare system because they don't trust it.
You know, that what you've just talked about, I can see that you're all about partnerships, and we can see that through so many things you've said. It also brings up a question I'm just dying to ask, and it's about your village at MetroHealth, and how COVID, the impact of COVID on the medical community. We've all heard about the shortages. You just talked about certain ways that that could be addressed, I think. But we've heard about the shortages, we've heard about the overwhelm. I just want to say, how are you holding up? How are you all doing there? And besides telehealth, has anything positive come from the pandemic in terms of healthcare? We see the emergence of the nurse practitioner, for instance.
So I will tell you is that people like me are the least impacted by the pandemic. Yes, sometimes we have to work long hours and the like, but the emotional toll this pandemic has had on the frontline staff. So we have to take care of them and be absolutely very grateful to them. As the Omicron variant was coming in, people are exhausted, and as we needed more staff. So MetroHealth past couple of months has had more inpatients than it ever has had in the past 50 years. Okay, so there were so many inpatients, and the staff were not built for that number of inpatients. So the staff was getting exhausted, and people said, "I don't want to do this anymore. I want to leave that." So we began a multitude of things, as simple as, Laura, as bringing in pets in the middle of the night, dogs, therapy dogs for the nurses and providers, and that respite really helps them a little bit. Okay, we began, the management team began working on the floors. So we're handling paper, giving patients their food, helping change the beds, these kind of things. That's an emotional uplift. And then the thing we did that no other health system has done is that we said, all right, we're making a lot more money because there are a lot more patients, right? I don't deserve that money. I'm not doing any more than anybody else. So the people who are providing the care are the ones who deserve that. So we put a system in place for premium overtime. And if you work your normal hours, you get paid one time. If you add another 8 hours to it every 2 weeks, you get 1.5. If you add another 8 hours to it, you get paid 2 times as much for all the overtime. If you add another 8 hours to it, you get paid 4 times the amount. If you add another 8 hours to it, you get paid 5 times the amount for all the overtime. So imagine if you are an EVS worker who's being paid $18 an hour. If they give us 20 hours of overtime or 25 hours of overtime every 2 weeks, right? For those 25 hours, they're being paid at $90 an hour. $90 an hour. And if you're a nurse, you're being paid at $200 an hour.
Wow.
So people began volunteering for this. And MetroHealth had no shortages because we took $10 million a month and gave it to our employees extra. We gave it to our employees because they're the ones who are doing the extra work, not me. So that has demonstrated to the staff that we understand how important they are and we want to care for them. I can't bring in more people, So I'm asking people to do more, and as a result, we've paid them appropriately.
That's a very ethical thing to do. I agree. And I have a question that a couple people have asked, Cheryl, an anonymous one. They're talking about substandard housing. So for hospitalized patients who are being taken care of home, what percentage of homes are really adequate for the site where that care is received, especially if it's really chaotic? I mean, I've been in houses where, there's really not a functioning bathroom right near where the sick person stay, and cleaning issues. And then there's the issue of food needs of persons on liquid diets or moving to soft diets, and the people at home are trying to understand that. Is there the option for hospitalization in that case?
Sure, of course. So let me just try a couple of things. So if you look at the county in general, about 70% of the homes can be provided. Care can be provided in those homes. They're adequate. They're capable to do that. And regarding the diets, that is a requirement that in order for you to take care of someone at home and be paid as if you are taking care of someone in the hospital, you must provide all those services for them. The physical therapy, the food that they exactly need, all of those different things. And then the last thing I would say to you, Debbie, to answer to these questions is that there are alternatives to the model to be able to be provided. If you have an unsafe home, a hotel room that is specifically equipped to do this can serve as a function for you and your family to go for that period of time, for that week, to stay at that place where it has all the equipment in place and everything else. It's still a 30% reduction in cost.
Right.
Okay, and people get better faster that way.
Laura, do you have one?
Yeah, Dr. Boutros, I think this question goes back to talking about social determinants earlier in your talk. And so it's a very interesting question. Please ask him how giving all the data is not seen as profiling or intrusion in the patient's personal life. The data about the patient, does that ever come to mind? Is there a little bit of tension there in terms of that information being so helpful, and then is it an intrusion?
So we can't use your information except with your permission. So that is first and foremost. So if you think it's an intrusion, you don't permit it. But I think the question was about using the large data. It's completely de-identified. We have no idea who it is. So we accumulate 300 million records into the Cosmos platform, 300 million records. And we see which medication has helped across these folks. We don't know if Laura was one of those patients, or Akram was one of those patients, or Debbie was one of those patients. It is completely de-identified. So the research tool that helps everybody is completely de-identified. The tools that we use and unite us and all of that, you must give us permission to utilize your data to refer you to someone else. So that's a very important question. Ethics is clearly important here about patients' data and how do we use them and why do we use them. Without their permission, we should not be able to use them.
There's a question about hospital care at home, which is so intriguing and I think seemed very attractive to many of us as you were talking about it. One of our attendees says, what about the caregiver who might be there at home? What about the stress on the caregiver? And is there any support for family members in the home who may be taking care of you at a higher level, with the hospital care?
Yeah, so just understand these are specific disorders that normally would be in the hospital for 2 or 3 days, not the folks who typically are in the hospital for weeks on end. And also it's at the end, sometimes for people who have been in the hospital for 14 days, it's the last 2 or 3 days of hospitalization that we can provide in the home, right? So it's not the very intensive type of care. But I'll give you an example of a program that was when before I came to MetroHealth, I helped develop 15 years ago, and it was regarding hospice care. Patients who are dying have so much need, unbelievable amount of need. They're in pain, they have respiratory issues, all of those things. And family, because they are so overwhelmed, they typically bring them to a hospital. They can't stand seeing the person in pain, and all of those things. In Texas, Aetna developed a program called Compassionate Care Program, and I helped design that program. And that program would provide all the services at home. So not only was there a nurse 24 hours a day with the patient, there was a social worker who worked with the family regarding the grieving process, regarding everything else before the patient died. And the patients, so before the program was done, they did a survey, and only 20% of the people gave the hospice process good marks. Now, 90% of the people give the hospice process good marks. And just so you know why this also makes sense for the Aetna to do this, they had an 82% reduction of ICU days, and it cost $20,000 less over the 2 years to care for the patient at home.
Wow.
So financially it was better, everybody was happy, and people didn't have to go leave work and sit by the bedside for hours on end. There was someone with the patient at home. So when they came home, the social worker would be there to help them, or the therapist to help them through that process.
I'm thinking we just have time for a couple more questions, and turning it back.
A couple of questions about metrics of success. An anonymous person would like to know the data on the health effects of your food program. And I noticed that the Institute of Health has a 5-year commitment, and the goal of the Institute of Hope is a 30% reduction in total healthcare dollars. Are these the proper metrics for success of these programs, and how do you measure these things?
Well, I will tell you that, regarding the food outcomes, it's actually been published. You would just need to go to do research on Google and look at the food insecurities and all of those results. Regarding the Institute for Hope, there are a lot of other metrics that we have. For example, the number of Unitas referrals that are closed, that means the patient's issues were addressed. We also look at the health of the individuals multi-year. The reason that there's a 30% cost reduction is to be able to make this self-sustaining.
Mm-hmm.
Okay, if we can't make this self-sustaining from a dollars perspective, other health systems aren't going to do it. We will stand alone as one health system that does that. That's not enough to take care of the entire community. If we can demonstrate that you can reduce the total cost of care for these patients by providing addressing the social determinants of health, everybody will come on the bandwagon. Everybody will be on the bandwagon, and we'll be able to move it along. And so far, we're well on our way to show that this actually works. We did, during the pandemic, we looked at, I think, about 800 patients over 65 years or older, and looked at social isolation, which was the #1 thing they said that they had was social isolation. Those patients had more emergency room visits, more hospitalizations, and a longer length of stay in the hospital. If we can prevent social isolation, we should be able to reduce the total cost of care.
Lori, one more. Oh, you're done? You have a question?
Yours, Debbie.
No, that was it.
Oh, okay.
Ask no more. Or is there
Oh,
anything we should have asked?
We do have a number of others. Actually, we haven't gotten to all of them. So one more.
You go.
Oh, this is an interesting one about lead poisoning. And
Yep.
so one of our attendees is interested to hear how MetroHealth is addressing lead poisoning.
So we've been running a lead clinic for over 30 years, 40 years, and actually have done it for the city of Cleveland. We have been able to identify lead levels early on in patients and help mitigate. It's mostly because of where the patients have been living. So we have in our lead clinic and in many of our MetroHealth locations, we have a partnership with legal aid. We have four lawyers who sit at MetroHealth from 9 to 5 every day to be able to advocate and move these patients quickly to new housing that is safer. Now, I also applaud what University Hospitals has done. They've helped us figure out some hot spotting so we can track every patient, no matter where they're living, and figuring out how lead is being transmitted. And as you I think may have seen recently, the Cleveland Clinic is putting in some dollars across the next 5 years to mitigate lead pipes and lead containing paint. That is how 3 institutions working together with different expertise are dealing with the lead crisis.
You know, I could listen to you for hours more, but I think our time's about come to an end. And I'd like to ask if there's any couple of sentences you would like to say at the end of our time together.
I would just say this to you. I'm an eternal optimist. And I would say in time of darkness, all we need is hope. And that is why MetroHealth has a new tagline. And it says, we say, devoted to health, hope, and humanity. That is our new tagline. That is what we are about: health, hope, and humanity.
And you
if
have the
we do that,
Institute of Hope.
yeah, and if we do that, if we just focus on being kind to one another and the future, I think we will all be much better off.
Thank you.
Thank you very much. Thanks for having me.
I think we have
Okay.
Jonathan coming
Yes.
back here.
Akram, I want to thank you, Dr. Boutros, for an excellent forum on the HOPE program, on everything that Metro is doing for underserved residents in our community. We truly appreciate the healthcare expertise, creativity, and commitment that you've given to MetroHealth's patients and to the entire Cuyahoga County community. I have to thank you for the scribes. It helps me immensely, and all the staffing initiatives that have helped us get through this pandemic on a personal level. It's now time for announcements. Yeah, we had to cut the questions short. We would have tied you up all day. Next Sunday, January 30th, our forum is titled Democracy, Nonprofit News, and the Future. Our nonprofit news panel includes top management of the Heights Observer, NEO Solutions Journalism Collaborative, and the Observer Media Project. We all know that fake news, lies, and manipulation of facts is on the rise via social media, radio, and TV. This will be a good discussion. 2 weeks from today, our speaker will be the Director of Inflation Research at the Federal Reserve Bank of Cleveland. He'll also give us an update on this important topic. I also want to ask if you want to receive an email reminder of future forums. If so, please go to the chat box button on your screen and put your name and email address there. We'll add you to our email reminder list. Today's forum has been recorded and it will soon be available. Go to our Unitarian website, uucleveland.org, and click on YouTube. We'd like to invite you all to our virtual Unitarian service at 11 o'clock. Reverend Dr. Randy Pertain will be speaking on the paradox of the sacred, a discussion on the fourth Unitarian principle. To participate, go to uucleveland.org and click on the square in the upper right-hand side of the website. The YouTube link will link you directly to the 11 o'clock service. Thank you for joining us today. We appreciate your support and look forward to seeing you next Sunday at 9:30 for our forum on objective community news coverage. And Akram, I'll see you pretty soon.